The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Before I start, I'd just like to acknowledge the actual instigator of this project, Dr. Bev Duff. She can't be here today, but this is actually her work and I'm reporting on this. So, and I'd also like to thank the organising committee for allowing me to speak. Lots of people have put up pictures of their hospital, so I didn't want to be outdone. And this is the new Sunshine Coast University Hospital that opened in March this year, although this wasn't the place where this intervention took place. The local hospital, Nambour Hospital, the local hospital, introduced rapid response systems in 2011 in accordance with best practice guidelines. And what they found after introducing those rapid response systems was that there was a significant underutilisation, as we already know from the evidence and the literature. But they're actually having less than 20 calls a month when they first introduced it, and that's for a 400-bedded hospital, so significant underutilisation. So what they did then was they developed a multi-modal education program with the aim of improving MET activation. And I do feel that everything's sort of been said as we get to the end of the conference, and Matt really spoke very nicely about how education can improve MET activation, but also recognition and response to deterioration. So I do think I'm sort of being a bit repetitive. But what we do know is that a recognition and response to deterioration is often not done well, and it's often not done well because we don't understand about deterioration. We've got a lack of understanding where hierarchical silos of care prevent us escalating care, that we have organisational structures that prevent us recognising and responding to patients, and we're fearful of activating or escalating care. And I put this picture up of Lewis Blackwell. I think I put it up for a number of reasons. I first heard about Lewis when I listened to his mother talk at the first Rapid Response Conference in 2006. And it was actually listening to Helen Haskell, his mother, talk about what happened to Lewis that prompted me to do my PhD in rapid response systems and nurses' reluctance to activate rapid response systems, but also to recognise and respond to patient deterioration. So I think this message here is that we take a lot from these conferences, we take a lot of knowledge and understanding, and we hopefully can go back to practice and think about what the gaps are in the literature, what the gaps are in our understanding, and how we can improve care for the patients. And as a senior lecturer, I beat the respiratory rate stick to about 500 students a year. So hopefully if I can go out there and get 500 students to talk about respiratory rates or do respiratory rates properly, I think, you know, I've done a pretty good job. So, and that's really because of listening to Helen talk about what happened to Lewis. But in response to the ongoing issues, there's been numerous educational programs implemented, the ALERT program in the UK, the STEPS program here, and Compass, Between the Flags. So lots of education programs have been implemented. But what we don't know is how effective these programs are over a prolonged period of time. So what did we do? We examined the impact of a multimodal educational strategy on nurses' recognition and response to patient deterioration. We hypothesised that participation in this programme would change nurses' self-reported technical and non-technical skills, attitude, knowledge, decision-making in relation to patient deterioration. Importantly, we also aimed to test Buckley and Gordon's survey instrument that they developed when they implemented their emergency recognition and response to deterioration, so that we hopefully were able to identify a clear and valid survey tool for future users of educational programs to test. So we did a quasi-experimental time series design, again in a 400-bedded regional hospital that serviced approximately 350,000 people. We had a convenient sample of RNs and ENs working in acute medical wards who enrolled on the programme. We had 4 data collection points 2 months prior to starting on the course, immediately before the course, immediately after the course, and then 3 months following the course. What was the intervention? It's a pre-reading of 5 e-learning modules, and those 5 learning e-modules were sourced from the web. I think Alex today spoke about using web resources or resources that you can access easily. They were actually the modules from the Detect program that Teresa Jacks developed. So participants read all 5 learning e-modules, and then they attended a deteriorating workshop, and then importantly they worked for 4 months with a clinical coach that supported them in the clinical learning environment. So what did we find? 45% of staff responded at all time points. The majority of participants were registered nurses, which isn't surprising really. There was a small percentage of ENs, but 51 or 85% were RNs. The mean age of participants was 40. So again, no surprise, we're getting an older workforce. Most of the participants, or quite a significant amount, obviously were female, again replicating the workforce, and the highest degree of qualification was a bachelor's. So then we did a confirmatory factor analysis on the 15-point survey instrument, the 15 scale, and we identified that this scale did actually factor in for non-technical and technical skills, and so we were able to confirm that it was actually a valid tool for measuring what it aimed to measure, which was do these courses improve technical and non-technical skills. I won't go through all of that, but you can see that most of those factors or components were above 6, so clearly indicating that this was a very valid tool. Because we were then able to assign a score to each of the participants, we were able then to measure their improvements in technical and non-technical skills over the time period. And what we found was that their technical and non-technical skills, knowledge and attitudes remain the same at the first 2 time points, so 2 months before and then actually on the day of the workshop, and then significantly improved and stayed improved for the time periods following the workshop. Interestingly, technical skills then started to tail off after the 4-month time period, which would indicate that perhaps people needed a refresher in those technical skills, but the non-technical skills remained high, but both results were statistically significant. We then asked what was the most useful aspect of the programme, and over 80% of participants identified that patient advocacy and assertiveness were the most useful. So again, those non-technical skills were identified as particularly relevant and highly important to participants. All participants identified that they were able to improve their recognising and responding to patient deterioration, but again, over 85% identified that their their ability to recognise patients who were deteriorating had improved, and that they were more confident and more able to respond. So again, the top 1 to 4 indicating those non-technical skills. We then asked after the workshop or after the programme, what sort of events or types of incidences were participants exposed to in relation to recognising and responding to deterioration. We found that chest pain was the most frequent incident, followed by changes in level of consciousness, and then alterations in their respiratory function. And again, this is replicated in the literature and would really confirm what Darryl Jones's paper talked about, I think in 2014 or 2012, about the epidemiology of MET calls, and talked about the deteriorating patient syndrome, and highlighted that we can actually work out which patients are going to deteriorate and start to develop algorithms for those types of incidences. So what does this mean? Well, we identified over a prolonged time that multimodal education programs can improve recognition and response to deterioration. We identified a valid and reliable tool that future partners or future educators can use to assess the effectiveness of their educational programs. And we identified chest pain, altered level of consciousness, and oxygen saturations of less than 90 were the most common cause of patient deterioration. And we argue that this finding supports the concept of the deteriorating patient syndrome and argue that there are potential for developing bundles or algorithms to manage these syndromes in the future. Thanks.